Hello everyone, my name is Lilian Mburo and I'll be doing my PowerPoint slide presentation on timely surgical referral for epilepsy patients. My PICO question is as follows. In adults with medically intractable epilepsy, what are the effects of timely identification in an epilepsy clinic compared to no process on surgical referral percentages? Definition. The patient population includes all adult medically intractable epilepsy patients. The interventions are timely identification and surgical referral placement. There is no comparator in place, and our outcome measure will be surgical referral percentages. For gap analysis, we found that all patients should be offered a chance at surgical evaluation whether or not they undertake any surgical procedures. Many patients wait for prolonged time before establishing care in a surgical epilepsy center. Our epilepsy clinic currently does not have data on what our surgical referral patterns are. Evidence for this intervention includes a 2011 paper published by Engel that noted misconceptions and biases among primary care providers and general neurologists regarding epilepsy surgeries. A paper published in 2010 by Hanif and his colleagues revealed that average time between epilepsy diagnosis and the time that a referral for a surgical evaluation in general lasts about 22 years, which is way long. There also exists a gap in the time frame between when epilepsy patients are eligible for surgery, and that is after failing at least 2 anti-epileptic medications at therapeutic doses, and when they are identified and evaluated for surgery. We performed a SWOT analysis, and SWOT stands for strengths, weaknesses, opportunities, and threats. The strengths for this project include decreasing mortality and morbidity for epilepsy patients. Also, our clinic is entirely set up of epileptologists and epilepsy advanced practice providers, so majority of us endorse this project. There will be an increase in revenue for our facility from all the project procedures and imaging that can be undertaken when evaluating a patient for surgical process. We will also improve the efficiency of our surgical referrals for medically intractable patients. The budget for this project is going to be minimal, and that is a major strength in the current healthcare standards where the bottom line is always a big concern. Weaknesses include lack of patient compliance with follow-ups. We have to have the patients come in so that we can evaluate them, identify them, and then send them for surgical referrals. There also exists diversity in individual provider practices, and this may mean that there would be a range in time frames between when patients are identified and when patients get the surgical referral orders placed. For the epilepsy clinic, unfortunately, there will be very minimal direct financial benefits. Most of the procedural billing and imaging will go to the neurosurgery clinic. Our facility also does require has special requirements for any outside company providing funding for projects within the facility, and this may decrease the pool from which we are able to obtain funding for our project. Opportunities for the timely surgical referral innovation include new data, especially given the limited amount of data on surgical referral rates. With my research, most of the data published is at least 5 years old, so we need new updated data. The results of this project can be used for advertising by the facility to both patients and other referral providers. Publishing this information will increase discussion among in social media among the general community, referring providers and epileptologists on surgical referral rates, what we're doing great, what we need to improve in, and what should no longer be considered. There is also a great opportunity for companies that manufacture devices that are used for epilepsy surgeries to provide increased patient assistance and sponsorship. Threats for this particular project include lower cost of anti-epileptic drugs. For many patients, epilepsy is a lifelong disease and the monthly cost of medications can be prohibitive. If the cost was slightly lower, then there's a greater chance of patients not being interested in surgical procedures. There also does exist a patient and referring provider bias against surgery, and that may mean that fewer patients are referred to level 4 epilepsy surgical centers. A different threat would be newer, more effective medications. So for patients who are medically intractable, there's still a chance of a new medication that would be able to control the seizures. A last threat would be new updates regarding medical intractable seizure management and surgical referrals. And these updates are mostly undertaken by legislative and policy-making organizations, including the American Association of Neurologists, the American Epilepsy Society, and the International League Against Epilepsy. Our projected budget is a total of $800, $500 of which will be for data collection, data analysis, and publication. In addition to this, we will use the employees in our Neurosciences Nursing Research Center, that is a part of our facility that assists nurses with publishing their research. Equipment and programs are already in place. We will use what the clinic currently has. There could be additional hours incurred by our staff RN coordinator, and we are projecting 4 to 8 hours per month, which will be $200, and the clinic will be able to absorb that. The other team members are salaried, and so there will be no additional financial output. Justification for leading this project: I believe all patients deserve a chance at seizure freedom. And I'm also interested in improving epilepsy disease management. I work at our clinic 5 days a week, so I have great rapport with patients, staff, and also providers. As a member of the American Epilepsy Society, the Texas Nurse Practitioners Group, and the American Neurology Association, I have access to all the new updated information that's concerning epilepsy and surgeries. This project will give me an excellent chance to improve my leadership skills. Our team members will include 2 epileptologists, one of whom is the clinic director, 2 advanced practice nurses, one of whom will be myself, and our registered nurse clinic coordinator. My references are as follows: Gilliam and Albertson, who in 2011 published Identifying Epilepsy Surgery Candidates in the Outpatient Clinic; Hanif, Stern, Dewar, and Ingle, who in 2010 published Referral Pattern for Epilepsy Surgery After Evidence-Based Recommendation, a retrospective study; and Jere, Sander, Kieser in 2016, who published Surgical Treatments for Epilepsy, the Potential Gap Between Evidence and Practice. Thank you.